Hello everyone and welcome to Teaching Tuesday. Today we have Cassandra going to be talking to us about nutrition and critical care. Take it away.
Thank you for the invite. I should say to everyone, I was telling Tashina when I was asked to speak, I was a little bit worried about what exactly should I speak to with nutrition and critical care, because every subset of illness, sepsis versus burns versus trauma, all sort of has some different recommendations. But what I decided to try and focus on was more so one nutrient in particular, focusing on protein, because that is something that across the board we're worried about in critical illness, that we want to try and preserve as much lean muscle mass as we can, minimize that loss, which we know is going to happen over the course of illness. To give you a little bit of background, so about 10 years ago, the Canadian Malnutrition Task Force was formed, and it was looking at nutrition care specifically in Canadian hospitals. And it did so by looking at when patients arrived, it was looking at recent reduced intake in the week leading up to admission, to sort of identify patients that were going to be at risk for malnutrition if they were found to have lost weight in the last 6 months unintentionally and had at least 2 weeks of reduced intake. They flagged them as being at risk of malnutrition, and they follow those patients throughout their hospital stays. They would then do like a physical assessment to kind of see if they already had some reduced lean muscle mass, if they further lost muscle mass over their admission, what some of the barriers were to them getting nutrition throughout their admission, what interventions were done, if any, and then sort of impacts that malnutrition had in sort of length of stay, readmission rates. And what they found, and I should note that this was they only looked at patients who were admitted not to an ICU, but this is going to be important because they couldn't include the ICU patients because they couldn't ask them those 2 screening questions on a regular basis, because if they're coming in intubated, we can't ask them, have you had unintentional weight loss? Have you been eating less than normal for 2 weeks? So we already know that our ICU patients who are going to be a direct admit are already a higher risk for malnutrition, likely already have or are starting to lose some lean muscle mass, but it's important for those patients that are starting on, I'll use my own Florida as an example, but if they're starting on 3C North and they're there for a few days, a few weeks before they come to us, 1 in 2 of those patients are already arriving at hospital with some degree of malnutrition throughout Canada. They found in this study that 75% of that time throughout their admission, that was going unnoticed or untreated. So those patients weren't getting a consult to the dietitian, so there was no nutrition interventions being done. So that's important to us because if a patient is on 3C North for a week or 2 weeks before they come to us and it's not been addressed, they're going to be even further malnourished by the time that they come to us, and it's going to become harder for us to correct that protein imbalance that they've had. They found that throughout Canada, they estimated that 1 million patients a year are eating less than their meal trays while they're admitted for reasons other than just being the hospital food. That wasn't always the reason. But on average, just in these patients, again, this wasn't including the ICU patients, but just in these patients on the ward, that malnutrition is increasing hospital length of stay by at least 3 days, and they average that it's going to cost the Canadian healthcare system about $2 billion a year. So this is important for us to recognize that, again, one of the big factors that they were looking at was that loss of lean muscle mass, because we know that has complications with that length of stay, recovery time, increased infection rate. And then anytime that you have trauma, infection, diseases that are present that are going to make that inflammation even worse, that undernutrition is going to become even more of a challenge to overcome. Certainly, we know that there's going to be times where that presence of malnutrition or that presence of lean muscle mass loss is going to be really prevalent to us. So our tea and toasters, our 80-year-old lady who comes in and eats like a bird, we know probably visually right away we can identify her at risk. That cachectic cancer patient, we can identify right away they're at risk for malnutrition. But there's also times that it's not as evident. So we can have someone who's over 65 years old, they look fit, they look well nourished, but just by being over 65 years old, naturally the aging process, they've already started to lose some lean muscle mass. Certainly people who come in looking like they're fit, so the 20-year-old football player, if he comes in septic, he's automatically going to be starting to lose some of that lean muscle mass day 1 of admission. And this picture that I put here, so this is Paul Wishmeyer. He's one of the big names in nutrition. So he's actually an anesthesiologist, I believe, studies at Duke University, but he's done a lot of nutrition research. And he actually in 2014 had an ICU admission for an obstruction. I think he did Crohn's, was on TPN for a while, but you can see how fit he was beforehand. In just a month in the ICU, he lost 20 kilograms. That's essentially all lean muscle mass. So the concern with that is that those negative outcomes when we're losing that lean muscle mass, certainly frailty, challenges with mobility, increases rehab time, increases both ICU and hospital length of stay for those that survived. Generally, the 1 year, 3 year, 5 year survival time is going to be lower. We know that we run into a lot of glycemic control issues too, because that muscle bed is where we dispose of our glucose. So as we're losing lean muscle mass in the ICU, we might be running into issues with our blood sugar control, with our insulin sensitivity and resistance, and also just based on our immune status. So knowing that many of our patients are arriving to us with that low muscularity, but also that through their illness, they're going to continue to lose that muscle mass, increase the risk of these complications. That's where one of my primary nutrition priorities becomes, what can I do through my feeding strategies to try and improve these patient outcomes? How can I minimize that lean muscle mass loss? So the first thing that all of the guidelines are consistently recommending, so Canadian, American, European, they're all saying that ideally we now want to start feeds as early as possible. So a while ago they would say, well, let's kind of like wait it out for a little bit, especially if they look well nourished coming into this, if we consider them low nutrition risk. But now they're starting to shift that thought to say early is better. So ideally, most of them are saying within 48 hours. Gold standard would be if we can start feeds within 24 hours, right? Recognizing that yes, sometimes we will always want to get them off the ventilator as early as possible. So if we can get them off the ventilator in 2 days, that's great. But what's 1 day of trickle feeding going to do to hurt them? It's not. If anything, it's going to try and reduce that gap in protein loss that we already know is going to happen over the course of their stay. So everyone's recommending that we feed ideally within 24 hours. Certainly there's going to be times where that's not possible. So obstruction, uncontrolled shock, if they have that active GI bleed. But this is with enteral feeds. TPN is going to be different. We don't want to feed right away to TPN because there's bigger risks. But if there's no contraindications to tube feeds, ideally you want to be feeding within 24, at the latest 48 hours. I know that we've all seen this, or we think, well, they're going to be extubated tomorrow, and then they're not extubated. Well, we're going to try again tomorrow, so we won't start feeds today. And then 3-4 days later, now we're starting feeds. So we're 3-4 days potentially behind. We've started to lose some of that muscle mass. So this isn't saying that we want to start and progress feeds right away. It's saying that we at least want to start feeds right away, start some trickle feeds right away. That's going to help support our gut integrity, so all those little microvilli in our intestine is going to help support those. It's going to modulate that stress response, reduce the disease severity, so it's going to help with that glycemic control. And again, it's just going to try and close the gap for some of that malnutrition that we know is naturally going to happen over the course of critical illness. The next step that we want to look at with nutrition is sort of our dosing. And this is a shift in guidelines over the last few years even. So we know now that protein is going to be a lot more important than overall calories, especially in the early phases of critical illness. So what data has been showing us that by hitting those protein needs, at least 80% of what I sort of assess them as needing, is going to be a lot more important in that early phase of critical illness than hitting those calorie intakes. So I've been in and out of this role for about 6 years now, and a way that you might have seen this happen is that when I first started, all of the research was saying, let's get them to target as quick as possible, let's give them those calories. So previously, there was a lot of mixed tube feed, so promote and tube out in these like right away as a starting dose. That's because protein, or the promote gives the protein, but the tube cal really calorie dense. That's where we were hitting those calorie needs. But now what you're probably seeing is that I'm using more promote as a start, and then day 3, day 5, now I'm switching them to that condensed. So what we're seeing The early phases of critical illness, we want to get them to that protein target as quick as possible, hitting 80% of their protein needs by day 3. And then by day 5, now we're starting to hit those calorie goals. So we don't want this like long-term calorie deficit, but in the early phases, we actually know that if we're overfeeding them too many calories, it's actually going to make their blood sugars a little bit more difficult to control, higher insulin needs. So the research is now suggesting that we actually underfeed on calories for the first couple days, but really focus on getting that protein into them as quick as possible. And we also know that our protein needs are higher than what we previously were sort of expecting. Part of that too is also looking at some delays to getting feed, so frequent stops and starts and holds and for tests. So just because we order it doesn't mean that they're always going to get it. So that's why they're kind of saying too that we can start to shift our protein needs up a little bit. That's including in the renal patients. Certainly a renal patient who's not on dialysis, we still want to restrict them a little bit, but some of the recent research for patients who are on dialysis, especially the ones on daily dialysis, are saying that we can go up to like at least 2 grams of protein per day. Not quite that aggressive, but that's what some of the research is starting to look at now. So some facilities have started to make this shift in providing protein also in how they're running their feed. So we haven't changed that here. I've been changing sort of what I'm using for my dosing of protein. So I'm starting with that promote and then shifting to a mixed feed. Some places are starting to look at if they're running them as a rate-based versus a volume-based feed. So we run a 24-hour feed, but an example of someone who's going to change to like this volume-based feed is instead of giving 1,800 mils of promote at 75 mils an hour for 24 hours. Some places are going to do that 1,800 mils at 100 mils an hour for 18 hours. And what that does is if they say that we're going to run from 6 until midnight, well now if the patient's on hold for 2 hours, they're going to run them until 2 a.m. So they're running it for 18 hours. So that's how some places are trying to kind of fill that protein gap a little bit. There's starting to be a little bit more research about volume-based as far as boluses, but so far the research isn't great there, and that's why I don't use that here. The next thing that I'm looking at when I'm dosing protein is keeping in mind that not all proteins are going to be created equal. So they're not all going to be digested the same. They're not all going to have the same sort of quality to help synthesize that protein. So again, what I'm really looking at is I not only want to give enough protein, but I want to give something that's going to help minimize that muscle mass loss, but also help synthesize new muscle mass. And what we know is that complete proteins have leucine in it. So a complete protein has all 9 essential amino acids that we need to help build muscle mass. But in acute illness, when we're really kind of burning through that muscle mass, really want to try and build more, we need more leucine than any other amino acid. So whey protein has more than like a soy protein or a collagen protein. So we're really focusing on trying to use a whey or a casein. Most of our products are going to be a mixture of those two. But the benefit of whey is that we digest it quicker. So it's going to be digested quicker, and be able to start to use that leucine quicker to rebuild that muscle. It's also better for tolerance. And I'll show you. This would be our formulas and our examples when we start to digest it. So that whey protein, easily digestible, it stays liquid in the gut for longer once that gastrin starts to digest it, as opposed to the casein. You can see it's starting to turn a little chunky there. Most of our formulas in hospital are going to be a combination. Part of that is availability. We don't have as many options that would just be a whey protein. So we're going to be a little bit limited in high protein versus renal friendly products versus diabetic friendly products. So we can't always have a 100% whey formula, but what you will see me using to try and optimize that easily digestible, easily usable protein is in the powders that I'm using. I guess that I use a powder and not the liquid. I have had a number of you ask why I use the powder instead of the liquid. I know that the liquid is more user-friendly because we don't have to mix it, but this is why. So that whey formula, we know that our patients are going to digest it quicker. It's going to be a lot more easily absorbable to them. So I understand that it can be more of a pain to mix that into the water. They both stink. So they're both smelly to give, but the Bena protein, it's 100% whey protein, so we know that it's going to be easily digestible, it quickly goes into the muscle bed to start to kind of use that leucine, rebuild some muscle, as opposed to the liquid protein, which is 100% casein. So sort of the absorbability is even going to be worse than what's shown on the right side of that picture because it's 100% casein. It's not that mix. And digestibility wise, it's pretty hypertonic too. So I don't know if you guys have noticed, but sometimes on the floor when I've given flushes of the casein product, you kind of start to hear some gurgling right away. It's pretty hypertonic, and so it can cause some diarrhea too. So that's sort of what I'm looking at from a tube feed point of view of how I can use protein to reduce that lean muscle mass loss, try and synthesize some new ones while they're here. So feeding early, feeding more protein, looking at a high quality, easily digestible protein. But I wanted to talk a little bit about our patients on oral diets too, because I do think that sometimes those patients are overlooked. We think they're on an oral diet, they're okay. But again, if we go back to that initial study, knowing the patients that are on the floors, 1 out of 2 of them are coming in malnourished. 75% of the time, they're not being addressed. I do think that that correlates here too, because it's not that often that if we have someone admitted on an oral diet, that I would get a consult. Now, what that study had found is that some of the barriers to patients eating well in hospital, again, not always related to hospital food. Here, I think that hospital food does certainly play a role. But some of the challenges that they found, again, these are more related to on the board than here. I think that we're really good at when a meal is missed, we do give them meal trays. We keep food for them after they've gone for a test, things like that. We're a little bit more one-on-one than up on the floor, so we can be making sure that we're opening things for them, that they're in proper positioning. But these on the floors are what some of our patients have been facing for the week or two before they come to us. So these are some of the barriers that they've been having to getting enough in before they come to us. So when they're here, some ways that we can help increase protein intake orally for these patients, certainly between meal supplements, so the MedPass program. I know that when we go to order that, it often says to give it like before or after a meal. Personally, I prefer to try and change the time to order it between the meals because the smaller, more frequent doses of protein are going to give them more access throughout the day. Plus that 2 cal is pretty heavy, so if they drink it before their meal, they might then get full, not eat as much of that actual meal, or they look at it and think, no thanks, I'll eat my meal instead. But I'll show you in a minute what some of our meals actually look like in terms of their protein content. Another simple thing that we can start to look at too, and I've been doing this recently with our patients who are being put on modified texture diets, is when the speech pathologist is saying give meds in applesauce, if we start looking at giving meds in yogurt or enteral pudding. And that could be simple. You don't have to necessarily consult me for it, but if you have a patient that speech has recommended that, just let me know and I can start putting it on their meal trays. Because if we look at one little tin of that applesauce, has 100 calories, but essentially no protein. Versus something like a Greek yogurt, same calories, but 8 grams of protein. So if they're having their pills in that, even if it's just 1 throughout the day, that's an extra 8 grams of protein. Or the enteral puddings, we can almost double the calories that they're getting. So for some of these patients, that can be pretty significant if we think they're having one of these every day for a week that they're here, or depending on how long their hospital stay, it can add up. It can help close that gap for that calorie and protein deficit that they're going to have over the course of their stay. Certainly the other thing that you can do, I might eat my words in a couple of weeks if consults go through the roof, but you can consult me, particularly for people that are picky eaters, that they have multiple dislikes. If you see that they're eating less than half of their meal trays, and this is a big one because I looked at a few patients last week who I didn't have consults on, but I looked to see their first day of a diet, what were they going to be getting? Because day 1, they're not getting a menu. So they're going at least 1 day with meals that they didn't choose, possibly more. Because if we put a diet order in for them today, they're not going to get a menu until tomorrow for the following day. So oftentimes it's 2 days that they're not going to get something that they get to pick. So if they get milk on every meal tray, but they don't like milk, right? Well, they're not going to eat that. So this is some examples. So we had a patient on full liquid diet last week, and the first day of meals was going to give them 1460 calories and 49 grams of protein, right? On average, a 60 kilogram patient in the ICU is going to need at least 1,800 calories a day and 90 grams of protein. So that's not hitting that. Add on to it that this patient hates anything chocolate flavored, right? Half of that calorie intake was from supplements, was from an instant breakfast on every meal tray. So 2 of the instant breakfasts were going to be going as chocolate flavored. So right away, that patient is now getting less than 1,000 calories a day. I'll also note, I didn't let this continue once I sort of involved myself. I didn't only spend on this, but this is what they were going to get. Someone who speech saw would put on mechanical feeding difficulties diet, was going to get more protein, but actually less calories than the person who was on full. And again, this is assuming that they eat their entire meal tray. So this is where it's really important that if you see that they're not eating their entire meal tray, that yes, give me a consult, because, and again, it doesn't necessarily be that they're doing lots of things, but it could be ordering the med pass or just changing a few of their preferences or putting a snack in the evening just to try to top that up and reduce that deficit that they're having. And this one was interesting, someone on a regular diet. And I sounded, when I was looking at the meals, I thought, this sounds okay, because I think it was a tea biscuit, a piece of cheese, some cream of wheat, and some milk at breakfast. It was like an egg salad sandwich and soup and milk at lunchtime. And then it was chicken, rice, green beans, a cookie, and some milk at supper time. Sounded not that bad, but it was less than 1,400 calories and 63 grams of protein that they were going to get if they ate that entire, everything on their tray all day long. So if you have a patient who's eating half of their meal tray or less, then they're almost at more of a disadvantage than those 2 feed patients. And so this is where sometimes I think that we kind of overlook these patients because we think, oh, they're on an oral diet, they're okay. But again, we know that nutrition is going to play a role in their recovery. We ideally want them, when they leave our doors, to go to the ward, continue their recovery, and go home. But unfortunately, nutrition, if they're falling behind in that, the bigger the gap gets, the more that door is going to become a revolving door. And we know that people who were coming in from this study who are arriving at hospital with some degree of malnourishment on arrival have a much higher rate of return within 30 days of discharge than those who either were well nourished on admission or had some form of an intervention during their admission to help improve that nutrition level. So overall, from my point of view for nutrition, what I'm looking at is I'm looking at feeding my patients better protein, so trying to get more protein into them and earlier into their admission so that they can be more likely to leave here stronger, hopefully soon. And that's all that I have.
That's great. So with your burn patient, is it the same?
For burn patients?
Yeah, because they eat those calories.
Burn patients are even higher.
Even higher,
Yeah,
right?
burn patients are
But
even
you
higher.
still do the protein, focus on your protein for the first few days?
Still want to focus, yeah, so they're, and that's where they're going to be a little bit different. We still,
Right.
we definitely want to advance them a bit quicker.
Yeah.
Yeah.
Okay.
So those are absolutely almost in every case we want to burn to be starting to feed within 24 hours.
Yes.
Yeah.
Yes.
And progressing within 48.
Yeah.
And then with everyone else, we say ideally within 48 at least starting a triple feed. But yeah, so your burn patients, you're going to be trying to advance them quicker because the deficit's going to be that much bigger. Some of your sepsis patients, as long as we know that they're stable, that any vasopressors that they're on aren't kind of trending up, then we want to really be focusing on protein. We can start to advance them a little bit too.
What percentage of protein would you guys use for somebody who was a burns patient?
With a burns patient, a lot of times, and again, this is where it gets tricky too based on their weight a little bit. And I guess how, like percentage-wise, how much their burn is, but it would often be 2 grams per kilogram that I'm looking at for them. For most patients, I'm looking at 1.5 grams per kilogram. So if we think so us, well-nourished, no critical illness, recommendations are 0.8 grams per kilogram. So critical illness, we go up to 1.5, burns up to 2. And that's where it's hard too, because yeah, critical illness can cover so much different things, and there's lots of research coming out too. Well, I mean, right now a lot of the research is on COVID and feeding during proning and things like that.
Are you supposed to feed during proning? You're the guy that was fed during proning, but it seemed odd to be like laying someone and then it just seemed very weird. But there was a spot.
So the issue, I guess, the concern with proning is that if we don't find a way to at least feed them something when they're proning, that their nutrition's going to get that much further behind because they can be proned for so long. And we know that when we put them back in the supine position, we're probably not going to be able to then just like put in a leader really quickly or anything like that. So some of the recommendations coming out right now, especially with all the COVID research that they've been doing and knowing that proning is quite common with that, is that we hold the feeds for an hour on either side of proning, and we would trickle feed during proning, but when we get them back in supine, then we don't get rid of.
And I guess that's what we've done. We haven't gone full feeding during proning that I know of.
No.
It's just been a kind of a
It's
trickle,
usually been a
or
trickle.
like maybe half of your max rate.
Yeah.
But never to the full, and holding it before.
Yeah, hold for an hour before and after, still feed them, but yeah, like 10 to 20 mils an hour. And I think when we've done it before, we've also been knowing that they're proning. That's probably where before we've looked at too, like that more concentrated, more focused on the calories. But now where we're focused, the shift is more so towards those the protein, especially in the early phase. Now we're considering sort of like using our highest protein possible during protein.
Okay, let's talk residuals.
Yes.
Let's talk about refeeding those residuals.
Yes.
Yes.
So
Talk about coping mechanisms.
let's talk about coping mechanisms when we have to give back that residual.
Right. So when we have to give back,
Are you comfortable to give 500 back?
no, you should only be giving 250 back.
Right.
Yes.
But that 250 is not being absorbed for another 6 hours.
So so the reason why they suggest to refeed some of it is because we know some of the electrolytes might have already been starting to shift and things like that. So we don't want to refeed all of it, but yes, refeeding. So once you're hitting that 250, that's where we're getting our order for Maxran. That's where we're So, and a lot of places right now too, so residuals are a bit of a hot topic because some places don't check at all.
What?
Some places don't check residuals at all.
So
So
they
some
just
of
wait
the
till they
trends,
vomit?
some of them are waiting for them to vomit.
Okay.
Yes. Some of the trends are suggesting that we look at other things other than, so I'm anti that, but we have gone from checking every 4 hours. So our recent update has gone from checking every 4 hours to checking every 8 hours.
8 hours,
And so really looking for more of that distension and other signs. So if we're able to ask them if they're nauseated or things like that. But really trying to early on optimize sort of the use of Maxran, bowel regimes, things like that. So some places are starting like the day that they start a feed, and I should say too, some of the places that aren't checking residuals, the day that they start a feed, they're starting Maxran right away. Whereas we're waiting for a residual to go high.
Yeah.
But again, do you want Maxran on everyone?
You don't.
You don't.
Because
So
Maxran itself has a lot of side effects.
exactly. So that's one of the big sort of debates right now. So yes, well, I would never refeed all 500. If you have 500, you stop the feeding and wait. But if you have 250, then. But if you have 100, don't stop the feed.
No.
Like our recent transfer, who feed was stopped.
Yeah, because of
Went on TPN because of 110 residuals. Rather than then try some Maxran or.
Sorry, I told them I'd be there at 8:30.
Any other questions?
I'm just curious about cardiac surgery and tube. So sometimes I find that patients are post-op a little while before a discussion or interest. Is there any contraindications to start early?
No.
Population.
So I would say they would still fit into critical illness, in my opinion, but ideally we should still be considering feeding early. And it doesn't mean that we have to feed, again, it doesn't mean that we have to start progressing them right away, but if we at least can start to feed them trickle feed early on to try and preserve some of that lean muscle mass, knowing that they're already going to be sort of malnourished. A lot of those patients are coming in malnourished, already have a gap. So yes, ideally we're trying to feed early on. I think that there's a lot of ongoing education that needs to happen.
Yeah, maybe they should have a teaching session.
I will say I have noticed it's been getting better.
A little bit.
Yes, it's been, so I was looking at, in nutrition, we were looking at stats recently as far as consults and what areas have been growing and what areas haven't been getting more stats every year. And the cardiac side in the ICU, over the last year, compared to the year before, there have been a lot more consults on that side, which is good, but I still think that there needs to be a lot more.
Or are we having more leftovers?
Right? Could be that they're coming, that we're getting sicker patients that are coming that much more malnourished, and now we have to address it. But they're here that longer, so we're starting it. That's a good question. But it would be similar in them too. So I've started to use more of like those higher protein ones, whereas knowing that they're always going to be on a fluid restriction. Before it tended to be use that Nafro or use that 2-cal, which is the most concentrated. Now we're kind of shifting away from that, saying, well, let's use one of our standard products like a Mo, which is high protein, and at least get that into them for a couple of reasons. For that muscle mass and for the protein, but also knowing that sometimes we're a fair bit slower to progress over there. Part of that, I need to start studying it and advocating a little bit more, becoming a little bit more feeding.
To the right people, not to the
So that's right.
Thank you. Yeah, there was lots of good stuff in there for us to think about.
chew on.
Exactly.
Thank you.